Last time we were discussing HIV infection and AIDS, and we have discussed various modes of transmission of disease, and we have seen how the initial infection is established. We saw that HIV has a low efficiency of transmission of disease compared with hepatitis B and C, both by sexual contact and by occupational exposure. This is because of various obstacles for the establishment of initial infection. But once it finds a target cell, which is of course the CD4 positive T helper lymphocyte, and in fact it starts replicating and is carried to the one of the peripheral lymphoid organs, like especially gut associated lymphoid tissue. There it starts replicating very rapidly, and at this time it is associated with a burst of viremia, where levels of virus may reach up to millions of copies per microliter. At this point, the infection is well established and the process is not irreversible. And at this time, patient may experience the acute HIV infection syndrome or the seroconversion illness, during which the patient may experience fever, generalized lymphadenopathy, a rash, or sore throat. And there is massive depletion of CD4 positive cells from the body. But this time it is associated with development of a robust immune response against the virus, so that the viral levels drop rapidly and the patient becomes asymptomatic. And the disease goes into a prolonged and variable period of clinical latency, during which the patient remains asymptomatic, but low-grade viral replication continues to occur, and there is gradually decline or depletion of the CD4 T helper lymphocytes from the body. Ultimately, after a variable period which averages about 10 years, when the CD4 positive lymphocytes counts drops below a critical level, patient starts to become symptomatic again, and ultimately with further depletion of the immune system, full-blown picture of AIDS with opportunistic infections and malignancies appear, which ultimately lead to death of the patient. This diagram depicts the all stages of the infection. This is the primary infection, burst of viremia associated with massive depletion of CD4 positive lymphocyte count. Then there is a robust immune response, which leads to a reduction in the level of viremia and partial recovery of the immune system, as evidenced by increased CD4 positive lymphocytes. And then there is a asymptomatic smoldering disease of clinical latency and gradual decline in CD4 positive lymphocytes. At this stage, patient becomes symptomatic again and finally develops full-blown picture of AIDS. Then we discussed the various complications of disease manifestation, and we saw that the major brunt of manifestations is faced by the respiratory system, followed by the gastrointestinal system. Then the various hepatobiliary, rheumatological, immunological, and hematological manifestations are there, which we have all discussed. Today we will briefly discuss the neurological manifestations of the disease. These neurological manifestations are quite common in the HIV infected patient, and if we take into account the asymptomatic abnormalities of CSF, we see that around 90% of patients infected with HIV have some neurological involvement. These manifestations may be due to a variety of underlying pathologies like inflammatory, demyelinating, or degenerative in nature. And these are the various manifestations. Most important are the opportunistic infections, which include toxoplasmosis. As I have already mentioned, this is a protozoan which usually causes in otherwise healthy people, causes a systemic febrile illness, which is self-limited. But if it involves the brain, then it is an AIDS-defining condition. Then cryptosporidiosis, cryptococcosis. The fungal infections like cryptococcosis, coccidioidomycosis, and histoplasmosis can affect the CNS. These are all AIDS-defining conditions. Cryptococcus is a unicellular fungus which usually causes chronic meningoencephalitis. It presents with headache, fever, nausea, and vomiting, and sometimes with cranial nerve palsies. It may also form cryptococomas in the brain. Similarly, coccidioidomyces, immitis, and histoplasma capsulatum can also affect the brain. Progressive multifocal leukoencephalopathy is, the name suggests, it is a disease involving the white matter of the brain and presents with multifocal neurological deficits, rapidly progressive disease caused by chronic infection by the JC virus. There is no cure for that disease, and before the advent of highly active antiretroviral therapy, the patients usually died within 3 to 6 months of the diagnosis of the disease. But now with appropriate antiretroviral therapy, we can expect a prolonged survival for these patients also. Then cytomegalovirus infection, if it is disseminated and especially involves the CNS, it can cause polyradiculoneuropathy or even encephalitis. Chances of developing neurosyphilis in these patients is also increased. Mycobacterium tuberculosis can involve the meninges and the brain, thereby leading to Mycobacterium tuberculosis meningitis or tuberculomas in the brain. Then HTLV1 infection, human T lymphotropic virus, usually involves the spinal cord and leads to spastic paraplegia-like picture. And MBBS, it can involve amoebic brain abscesses. Some manifestations of CNS can be directly due to the effect of HIV virus itself. Most important among these is HIV-associated neurocognitive disorder, including the HIV encephalopathy or so-called AIDS dementia complex. This is gradually worsening neurocognitive disorder manifest by difficulty in concentration and reading and loss of recent memory. But it is quite different from the other common dementias like Alzheimer's disease. Then aseptic meningitis can be caused by HIV itself, where we have increased protein and pleocytosis of the CSF and evidence of virus in the CSF, but other pathologies are not detected, so it is meningitis caused by the HIV virus itself. Chances of getting stroke are also increasing in these patients. This is probably multifactorial. For example, it can be due to vasculitis, which can be from infections or immunological manifestations, or by the accelerated atherosclerosis, which is commonly seen in HIV-infected patients. Then there are different types of myelopathy which can manifest in these patients. The most important is vacuolar myelopathy, usually presents with a picture like subacute combined degeneration with spastic paraplesias and peripheral neuropathy. Then it may manifest as pure sensory ataxia when dorsal column only are involved. Then HTLV1 associated myelopathy, which also presents with spastic paraplegia. Peripheral neuropathies also can be of different types. Acute inflammatory demyelinating polyneuropathy, which is also called Guillain-Barré syndrome, or chronic inflammatory demyelinating polyneuropathy or CIDP. These both are immunologically mediated. Then polyradiculopathy, usually caused by cytomegalovirus infection. Mononeuritis multiplex, multiple unilateral nerve involvements can occur, maybe both sensory or motor. Then distal symmetric polyneuropathy of glove and stocking type is also common in these patients. Then some patients may present with myopathy, with weakness, and finally wasting of the muscles. And the common neoplasms which are found in these patients are primary CNS lymphoma and Kaposi's sarcoma. Both of these are AIDS-defining conditions. This is a CT scan showing the classical ring-enhancing lesion of the cerebral toxoplasmosis, and this is the pathogen under the microscope, typical spindle-shaped organism, unicellular organism, protozoan. This is the CSF examination for cryptococcosis. You can see the dense polysaccharide capsule, which is seen against a dark background of India ink. This is primary CNS lymphoma, multicentric. You can see multiple lesions originating at different areas of the brain. Then certain ophthalmological diseases which are common in these patients. Most common are the cotton wool spots, which are whitish spots which represent regional ischemia due to vasculitis of the retina, which is the most common. But the most serious one is cytomegalovirus retinitis, which is an acutely sight-threatening condition. Other manifestations can be herpes simplex virus infection of the retina, varicella zoster involvement, toxoplasmosis of the eye, syphilis involving the eye, and even pneumocystis jirovecii, which commonly causes pneumonia in these patients, can also involve the eye. This is the classical picture of cytomegalovirus retinitis. You can see the hemorrhages and in areas of infarction and papilledema. Then the common malignant disorders which are encountered in HIV-infected patients. Number one is Kaposi sarcoma. It is a multicentric malignant disorder of the cardiovascular system. Kaposi sarcoma is caused by infection with human herpes virus 8. Lymphomas of various types are also very common, and patients have 120 times increased incidence of lymphomas compared with general population. Then cervical carcinoma in the women, this due to chronic infection by human papillomavirus. And multicentric Castleman disease is a lymphoproliferative disorder, not exactly a malignant disorder, but is also called by same virus, human herpes virus 8, which is responsible for Kaposi sarcoma. This presents with generalized lymphadenopathy, hepatosplenomegaly, and systemic features like fever, fatigue, and weight loss. This is a picture of cutaneous Kaposi sarcoma, but it can involve other deep organs also and mucous membranes. Now, briefly, lab workup for HIV and AIDS patients. The guideline for this is that all patients coming for routine medical checkup should be offered testing for HIV, but informed consent is important, and the patient should be given a choice to opt out, that if he doesn't want to get checked for HIV, it should not be checked. There are several screening tests which can be rapidly performed and have a sensitivity of more than 99.5%. They are usually ELISA-based, which detect antibodies against HIV. But once positive, they need to be confirmed by a confirmatory test, which is usually a Western blot test, which detects antibodies against all the major genes of the virus, including GAG, POL, and envelope genes. Then certain tests which directly detect the virus itself, for example, by P24 antigen capture assay or by HIV RNA by PCR, other techniques which also tell about the viral load, how much the viral copies are there in the serum. This is important in not only making the diagnosis of HIV infection, but also in establishing initial prognosis, determining the need for therapy, and monitoring the effects of therapy by testing for viral load. Then some investigations are routinely required for monitoring the progress of the disease and effects of the treatment. Most important among them is the CD4 plus T helper site cell count in the peripheral blood, which broadly reflects the underlying immune status of the patient. If the count is more than 500 per microliter, this is almost normal. The patient has no immunosuppression at this stage. But if the count is between 200 to 500, there is minor immunosuppression, and patient may have increased chances of developing infections by routine organisms like bacteria. If the count is below 500 but more than 50, below 200 but more than 50, then patients are at high risk of some opportunistic infection by pneumocystis jirovecii. And if the count drops below 50 per microliter, There are a risk of disseminated cytomegalovirus infection and disseminated infection by atypical mycobacteria like Mycobacterium avium complex and Toxoplasma gondii. These are the various stages of immunosuppression. Then HIV RNA determination for viral load, whether it is increasing or decreasing. Then before starting the antiretroviral therapy, HIV resistance testing should be done by genotyping or phenotyping so that we know if there is resistance to some drug, so that drug should not be included in the regimen. And other tests which can be potential markers for HIV disease activity, for example, like levels of beta 2 microglobulin, soluble interleukin 2 receptors, IgA levels, tumor necrosis factor alpha levels, and the presence or absence of activation markers such as CD38, HLA-DR, or PD1 surface receptor on CD8 positive T lymphocytes. These are the various tests by which we monitor the progress of the disease. Now, briefly about treatment of AIDS and related disorders. Regarding general guidelines about starting the treatment, first of all, as we have already mentioned, that there is a need for testing for HIV infection to be a part of routine medical care. But of course, the patient should be given a choice to opt out. If he doesn't want to get checked, it should not be checked. Then there should be pre-test counseling. We should tell that what it means, what is the impact of being positive for HIV. Then after patient is given all the picture of the possibilities, then should be given the opportunity to opt out. And after the patient becomes test positive for the HIV, then counseling for what are the options available and what are the future prospects. And this should be followed by routine evaluation and investigation. These are the routine evaluation which should be done when the patient is found to be positive for HIV. Of course, history and comprehensive physical examination should be done. Routine chemistry and hematology, including the liver enzymes and bilirubin. Then lipid profile and fasting glucose levels. CD4 plus lymphocyte count in the peripheral blood. Then 2 samples for plasma HIV RNA levels, HIV resistance testing for drugs resistance, checking for HLA-B5701 screening, which is a marker for hypersensitivity to the drug abacavir. If patients are positive for this marker, then this drug should not be included in the regimen because they are at risk of having severe reactions to the drug. Then rapid plasma reagent or VDRL test for screening for syphilis, antitoxoplasma antibody titers, APD skin testing for detection of incubating tuberculosis, mini-mental status examination to detect any neurocognitive deficiency if present, serologic examination for hepatitis A, B, and C. Immunization is recommended for pneumococcal and seasonal influenza vaccines. Then immunization for hepatitis A and B if patients are seronegative for these diseases. Then counseling regarding natural history and transmission so that patients should avoid transmitting disease to others, and then help contacting other people who might also be infected. There are 3 broad categories for treating HIV infected patients. Number 1 is prophylaxis for opportunistic infections, malignancies, and other complications of HIV infection before they occur. Once the immunosuppression reaches a certain level, they are at risk of developing all these complications, so that prophylaxis should be started. Then treatment of opportunistic infections, malignancies, and other complications of HIV once they have already occurred, and of course, treatment of the HIV infection itself with combination antiretroviral therapy. This last point is the most important because if we treat properly the HIV infection itself, and which will help increase the host immune response, it will itself take care of most of the diseases, and at least their treatment will be also made easy with an improved patient's immune response. These are the few important prophylactic measures against certain diseases in HIV patients. Number one is prophylaxis against Mycobacterium tuberculosis infection. It should be by daily isoniazid 300 mg orally with pyridoxine to avoid peripheral neuropathy 50 mg daily. For all HIV infected patients who are positive for PPD skin test. Positive test means that the patients are incubating the disease and they are at risk of reactivation of disease, so that it should be started if they are positive for PPD skin infection. Then prophylaxis against pneumocystis pneumonia. Patients should be started on this prophylaxis once the CD4 positive lymphocyte count falls below 200 per microliter. And this is by a combination of trimethoprim sulfamethoxazole, one double strength tablet, which is also with the trade name of Septrin, once a day. The other option is aerosolized pentamidine, which prevents only from pneumocystis pneumonia, but does not prevent from systemic infection. So the better treatment option is tablets of Septrin once daily. Prophylaxis against toxoplasmosis. Prophylaxis is usually required if patients test positive for IgG against toxoplasma. This means that they have been exposed to toxoplasma before, and once their CD4 count falls below 100 cells per microliter, they should also be given prophylaxis for toxoplasmosis. The prophylaxis is the same as for pneumocystis and carniae, so that the same treatment is effective against development of both these conditions. Same trimethoprim sulfamethoxazole combination, Septrin, one double strength tablet daily. And lastly, prophylaxis against Mycobacterium avium complex infection, and this is required once the CD4 positive cell count falls below 75 to 100 cells per microliter, and this is usually done by either clarithromycin 500 mg twice a day or azithromycin 1200 mg once a week. These prophylactic treatments are continued till the patient is at risk for developing these conditions. For example, once the CD4 positive cell counts rises above these levels, reference levels, and then these prophylactic treatments can be stopped. Now, regarding treatment of complications of HIV infection, briefly we will discuss cytomegalovirus retinitis, which is immediately sight-threatening condition. The preferred regime is intravitreal injection of gencyclovir once or up to 4 doses per day for 7 to 10 days, plus oral gencyclovir, which should be continued for 2 to 3 weeks, and this should be followed by a maintenance oral dose of gencyclovir 900 mg once a day. Alternatively, patient can be given intravenous gencyclovir at 10 mg per kg per day in 2 divided doses, and this should be followed by oral gencyclovir as a maintenance dose. Alternative regimes include foscarnet or cidofovir if the virus is resistant to gencyclovir. Esophageal candidiasis is usually treated by oral fluconazole 100-200 mg once a day for 2 to 3 weeks. Herpes simplex infection, recurrent oral ulcers and painful infection, is treated by acyclovir 400 mg 3 times a day orally for 5 to 10 days, or it can be given intravenously 5 mg per kg intravenously 8 hourly. Alternative drugs are famciclovir, valacyclovir, and foscarnet, last one being intravenously. Herpes zoster is preferably treated by valcyclovir 500 mg orally 3 times daily for 7 to 10 days, or famciclovir 500 mg 3 times daily for 7 to 10 days. Alternatively, it can be treated also by acyclovir 800 mg 4 to 5 times per day for 7 to 10 days. Or intravenous acyclovir can also be given in doses of 10 mg per kg every 8 hours for serious infections. Kaposi sarcoma, mild to moderate disease, usually does not require treatment, only treatment with antiretroviral therapy. helps optimizing the condition. But if the disease is advanced, then combination chemotherapy with daunorubicin, bleomycin, and vinblastine is recommended. Now, indications for initiation of antiretroviral therapy for HIV positive patients. 3 conditions are usually considered indications for starting the antiretroviral therapy. Number 1 is acute HIV infection syndrome. We have seen that during this phase there is massive viremia and marked depletion of CD4 positive cell counts throughout the body. It is estimated that 50 to 60% of total pool of CD4 positive lymphocytes are depleted during this phase. So that treatment during this phase is important. It will improve the future prognosis of progression of disease. Other one is during chronic infection, when the patient is asymptomatic but disease is incubating. Then in those patients who are having either symptomatic disease including HIV-associated nephropathy or dementia, or those patients who are themselves asymptomatic but either their CD4 positive cell count is below 500 per liter so that they are immunosuppressed, or pregnant women to prevent their transmission of disease to the infant. And third category is for post-exposure prophylaxis. This is usually recommended when the patients have accidentally been exposed by sexual contact or by occupational exposure to HIV positive people, and it should be given in a state of emergency. It should be started within 72-hour exposure, because after that the efficacy of starting antiretroviral therapy for preventing establishment of infection is usually useless. But nowadays, on the basis of the STAR trial published in September 2015, it's recommended to start treatment for all HIV-infected persons regardless of the CD4 positive cell count. This is because we have now developed potent antiretroviral regimes so that most patients can expect a near normal life expectancy and normal healthy living. 4 classes of antiretroviral drugs exist. These are number 1, those that inhibit viral reverse transcriptase enzyme, the virus that is responsible for making a DNA copy of the virus genome, so that this DNA copy can get inserted into the host genome and start replicating. This enzyme can be inhibited by different ways. Most important is by nucleoside or nucleotide reverse transcriptase inhibitors. These are actually nucleoside or nucleotide analogs and get inserted in place of normal nucleotides in the developing DNA, so that the resulting DNA copy is non-functional, as is useless, so that the viral replication is interrupted. And the other ones are non-nucleoside reverse transcriptase inhibitors, which are not the competitive inhibitors of the enzyme, but inhibited by alternative ways. The second categories are the drugs that inhibit the viral protease enzymes, called protease inhibitors. We know that when the messenger RNA is translated into protein, not the final product is produced immediately, but rather it is a pro-molecule which is further processed by cleavage at various points and final folding of the protein, which gives rise to the final product, which is the active protein. But if we inhibit the viral protease enzyme, then this post-translational processing is not possible, so that the resulting protease is inert and useless, and viral replication is interrupted. Third categories are those that inhibit the viral integrase enzyme, which helps integration of the provirus, the DNA copy of the viral genome, into the host genome, so that it cannot transcribe and becomes useless. And the fourth categories are those drugs that interfere with viral entry into the target cell. These are usually fusion inhibitors or CCR5 antagonists. This is a surface marker which acts as a co-receptor for entry of the virus into the target cell. If we inhibit this cell surface receptor, then the virus entry into the target cell is inhibited. These are the various points at which we can check the viral infection. This is entry inhibitors. This is the reverse transcriptase inhibitors. This is the integrase inhibitors, and these are the protease inhibitors after translation. These are the various examples of drugs in different groups. These are the nucleotide reverse transcriptase inhibitors. Zidovudine, the first ever drug produced for treatment of HIV. The other is didenosine, zelstabine, stavudine, lamivudine, emtricitabine, abacavir, and tenofovir. Non-nucleoside reverse transcriptase inhibitors: dalavirdine, nevirapine, efavirenz, and rilveripine. Entry inhibitors: these are the various entry inhibitors: enfuviritide, maraviroc, and integrase inhibitors, raltegravir or alvitragir. These are the protease inhibitors: secunavir, ritonavir, indinavir, nelfinavir, and these various. These are the doses and the side effects of these drugs. This is a very comprehensive topic and a specialized subject. We can only just briefly summarize these features here. Then finally, constructing drug regimes. The basic principles are only combinations of 3 or more medications from 2 or more classes have been able to decrease HIV viral load significantly and provide durable suppression of HIV RNA to below the threshold of detection. This is important because number one, single or 2 drugs are not so efficient also, and moreover there are more chances of developing resistance to these drugs. Then resistance testing should be performed prior to starting antiretroviral therapy so that we know which drug the virus is resistant to, and it should not be included in the antiviral regime. Drug resistance testing is also recommended for patients who are receiving antiretroviral therapy and have suboptimal viral suppression. So resistance testing is recommended also at the start, before starting the treatment, and during the treatment if the response has been suboptimal. These are the various combinations which are nowadays available. These 6 regimes are the most commonly used. These can be referred to by reference books. Now finally, prevention of HIV transmission. There are several measures we can take for prevention of HIV transmission. For example, antiretroviral therapy for decreasing transmission of HIV to others. For example, people who are positive and they have sex with other people who are negative. So preventing a transmission, they can start antiretroviral therapy so that their viral load is decreased and their chances of transmitting the disease are low. Similar applies for those HIV infected patients who are drug users and share their needles with others. Then pre-exposure antiretroviral therapy for prophylaxis. This is also recommended for those patients who are sexually active or who are drug users. Themselves they are HIV negative, but they are at risk of getting disease from others. So pre-exposure antiretroviral therapy is also found to reduce the risk of acquiring HIV infection in those people who are at high risk of acquiring the disease. Then post-exposure prophylaxis after the exposure to HIV. This includes the medical professional who have been accidentally pricked by a needle which is known to be contaminated with HIV positive person, or those those people who have been exposed sexually to people who are positive for HIV. They should be offered antiretroviral therapy within 72 hours and should be continued for at least 6 weeks. Then prevention of HIV transmission in healthcare setting. Universal precautions are required, especially for body fluids, and especially if there are splashes. They should wear goggles, the cap, the mask, and sterile gloves. Prevention of perinatal transmission of HIV by giving antiretroviral therapy to the mother so that the chances of transmission to the fetus are reduced. Prevention of transmission of HIV through blood or blood products by extensive screening for all blood and blood products before transfusion, and positive samples should be discarded. And development of HIV vaccine, which is still elusive. Only one study showed only modest protection by a vaccine, but it's not practical for clinical use. However, research is going on for the development of a novel vaccine for the disease. Finally, the most important determinant of treatment efficacy is adherence to the drug regimen. A combination antiretroviral therapy can successfully treat virtually all patients, and they can expect a normal life expectancy. Patients who are compliant with treatment should have near normal lifespan, but unfortunately, not all HIV infected persons have access to treatment. And it is known that less access is available to treatment for blacks, the homeless, and for injection drug users. And a protective vaccine may be possible, but clinical trials in humans have been disappointing, and only one trial provided evidence of modest protection against infection by a vaccine, which was about 31% protection, which is too low for clinical use. Thank you very much.